Okay, all right. Well, good morning, good afternoon, everyone. Thank you for joining us today. My name is Tanya Davis, and I have the pleasure of being your moderator for this panel discussion. It is truly an honor to welcome you today to our virtual panel discussion titled Breast Cancer Screening in Focus, Real World Solutions to Improve Access and Early Detection. And as we close out Breast Cancer Awareness Month, today's conversation is more about raising awareness. It's not just about raising awareness. It is about learning from real world examples of what's working across health centers and communities to improve access, to drive early detection, and ultimately save lives. And so we are joined by a phenomenal group of leaders who are on the front line of this work each and every day, and bringing valuable insight into how our FQHCs and their partners are designing and delivering high impact solutions. And how are they getting the word out, improving awareness? And so I am pretty excited. First, let me introduce Anna Hassan. Anna, you just raise your hand. Okay. So we have Anna Hassan, who serves as the Director of Practice Transformation at the American Cancer Society. Anna brings deep experience in population health, quality improvement, system change, and she leads national strategies to implement evidence-based programs such as cancer screenings and increasing cancer screenings and reducing delays in care. So we're happy to have Anna with us. Next, we have Dr. Wendy Cuttridge. Wendy, raise your you could just wave for Wendy, thank you. She is the Chief Quality Officer at Integrative Health Centers in West Virginia. She oversees the clinical quality across a network of FQHCs in West Virginia, and has been instrumental in advancing screening programs and sustaining patient navigation services to reach underserved patients in rural settings. And so we are happy to have her with us today. And then we have Mary Spencer there in the box with Wendy. And it's my understanding that Mary is you run and oversee and manage the navigation of the breast program.
Yes.
Mary.
Yeah.
Okay. I was going to say, please chime in and tell us what you're doing there.
Go ahead.
I'm the chronic care coordinator. I keep an eye on all of our quality measures and scrub charts and keep the people on top of things.
The most important job there at Integrative. Well, welcome to the panel. Welcome. We're happy to have you. And finally, we're honored to have Nuria Canizales. Nuria is the quality director at Baywell Health Center in Oakland, California. Nuria leads performance improvement, and she has played a critical role in launching a mobile mammogram program in partnership with Sutter and Stanford. So they are redesigning how they are reaching African American women and those in their communities to increase awareness and, of course, early detection. So with that, I am going to now move forward so that we can get started on this discussion. Oh, and let me not forget, we have Jessica here in the room and also Jennifer, who's here to help us continue to get this moving, this technology. We've been having some Zoom challenges today, but we're going to keep our fingers crossed that we get through this one. All right. All right, so let's just kick this off. I'm going to ask that everyone here just briefly describe And this is the question to all of our panelists. Just describe for us your cancer screening challenges in your organization, and what you are focused on today. So just kind of, what are the population of group that you're currently serving? What are some of the challenges, and how are you working through those challenges today?
I don't mind starting. I wasn't sure. So, as a rural state, West Virginia, it's really hard for patients to get to the screenings. So, it's transportation, whether that's access to it or what's available. Public transportation, in some of the rural counties really is non-existent. So, they have to rely on family and friends. There's also misconceptions about the getting a mammogram, what happens, what are the steps, what does it feel like? So really kind of navigating those discussions and making sure that they understand. And our patients, generally will have to miss work for the test. But in our state, there's also an issue of not just childcare, but elder care. So they're taking care of their parents as well as their children. So making sure that they're going to be able to get to that appointment is really kind of some of the issues we're having. That's on top of, underinsured, uninsured, across the board. So we really have to figure out how we can meet the patients where they are.
Thank you. Any of the other panelists? Thank you, Anna.
Yeah, I would like to share our experience. I think it is similar. So our patient really struggle with the transportation. That's why we create like internal referral, but works quickly means the MA, the provider, or the person who is talking with the patient can be referral department when they ask the questions to try to help them to bring them to the appointment. So if they identify the patient have issue with transportation, we immediately create that message in basket message as a internal referrals, and that team help us immediately to schedule transportation to the patient. However, even we have that opportunity, one of the big issue I can see it through the data is some of the contact information is not updated properly, and or because the condition of the population, so they change phones, so sometimes we cannot really reach the patient. That is unfortunate, and we are trying to create more awareness with the registration team when the patient come to the visit, try to update that information, because that is something really difficult, right? So, and I think the last one is when we don't have enough team to make a call, we start using care message. And at the beginning, the patient didn't respond too much, right? It's like a zero response. But we observe over the time, so they start to respond more to the care message. That helps us a lot to understand, especially if the patient really will be at the appointment, or they prefer to cancel, or because what we want to really understand is try to eliminate any barrier the patient has to go through the screening process. Yeah, that is our experience.
Thank you, Noria. Thank you for that. Wendy, so we're just going to move over to talk so we can learn a little bit about what's happening at Integrative Health. So tell us a little bit about your breast cancer program, and what strategies have been most effective in increasing your screenings and uptakes.
I think the strategies we've had is trying to optimize that access, the data that we have access to, trying to kind of go through that list and identifying where those care gaps are, and then also engaging the staff. So our nursing staff and providers as well, giving them tools that puts that data in front of them the day of the visit. So we use, we have daily huddles in the morning. So we have all of that information for the patients that are scheduled, and even walk-ins, because we do take walk-ins. They can pull the information to see, where the care gaps are, and that includes the breast cancer screening. So I think that's really what's helped us start moving the needle and keeping it at the forefront of the minds of our staff so that they're talking about it with the patients.
Great, thank you. Thank you for sharing. Noria, so just building on that, we know that your organization, your health center, just recently partnered with Stanford, and you launched a mobile mammogram program. So share a little bit about that, your program, and then what lessons have you learned from bringing screening directly into the community?
Yeah, we definitely are learning a lot about this partnership. First of all, I want to mention this is a really great opportunity for us. So both of the partner are really helping us to reach our most sensitive population, because we currently are focused in Black African American population, because they show up like a less rate of screening. So we start first. I will start first with the mobile mammogram event. We have monthly mobile mammogram. We had 22 spots available. So in one of the thing we had to create first was, okay, who will be the team who will lead in this process? So we select referral department. So in referral department was training how they have to identify, and we create a decision tree so they can pull the right patient in the mobile mammogram monthly basis. And also after they finish to create that schedule, that schedule move on to our department, and we finish just to verify the patient really qualify and have everything ready. And the third step is the MA team. The MA team, at that point, they pick the patient list and call the patient. So, but also we create 3 different care message, and between we try to be ready with the schedule 2 weeks before the appointment, so that give us time enough to send 3 care message. One is educational, the second one is a confirmation of the appointment, and one of those is just give the patient the opportunity to, if they have to cancel for different reasons, they have 72 hours in advance. We stop doing 48 hours. We want 72 hours, because that give us more time to put another patient. So that is if July was our first month, so the no-show was 60%. August, the no-show was 53%, but September was 23%. So we really finally improved that process. So we have essentially more patients who get done the mobile mammogram, and we are super happy. So, it's a process to learn, but also we create some workflow at the day of the event. So from the check-in, our quality team is walking the patient, receiving the patient, walking the patient. They give some education and education material also from American Cancer Society. And we also give some bags with fresh food after the patient finished, so that can give us the opportunity to keep that connection and engagement with the patient. And so I think that is one of the things can give us the best success for this experience right now. So still, right, so if we have some patient that didn't show up, we also offer the opportunity walk-in appointment when we have the band in the health center. So that is from Sutter. From Stanford, that is a different approach. So essentially, we share Epic link. So means we have the access to schedule directly in Stanford. So I think with Stanford, it's a great opportunity. However, we have a little, we struggle so far with the credential of the provider, because every provider should be activated to the system. And so we are still having some issue. However, what we start doing when we finish the process of educate the providers, teach them how they have all of those come from Stanford team. So they educate the provider, share with them the workflow, and I designed one of my team to work with each provider just to be sure they have everything set up. And already we start a schedule patient. So same thing. That project is only for Black African American population, and we already start in September. Our schedule start to increasing. So because at least we have 4 provider already activated, they finish the process, and referral team is who the responsible to set up the order in Epic Stanford, and the provider just go back to sign the order. So that's exactly the process we are doing. We change a little bit because our provider, they don't have too much time to create the order in Stanford, because we already have an order in Epic, right? In our Epic. So that process help us to bring more patients in our schedule right now. And the good thing with Stanford is they also have a patient navigator. So they go through the patient. Since the patient is in the schedule, they follow the patient with different intervention, like a care message, phone calls, just to be sure the patient can be at the appointment on time. And also, if the patient didn't show up, they send to back the list of the patient didn't show up, and we send some new reminders to the patient. They still open the order in Stanford, and they can reschedule again.
Yeah.
So that is a fantastic process. How I mentioned, we are still learning. And
Thank
some
you,
of the
Nora.
patients, yeah.
Yeah, thank you for that. Sound like, and congratulations on reaching those results. So just it's good to see when you're working together and you have your processes in place, how things you start seeing the numbers go in the right direction. So congratulations on that. We should say. And I'd like to hear from Anna as well, and because you do a lot of work collaborating, a lot of collaborations and partnerships. And so I'd just like to, one question we have from the audience: how have partnerships with hospitals, universities, or community-based organizations strengthened the work that you're doing and at the American Cancer Society?
Yes, thank you, Tanya. I love hearing from everybody what you've shared so far. I think some of them have been exemplified in the stories already shared. So by partnering with different organizations, you can expand your access. You can tap into more resources to leverage maybe larger systems that have access to more navigation services, like people time, like FTEs of navigation, but also maybe some subsidies for, depending on what state you're in, if you've expanded Medicaid, or for uninsured patients that might have a copay or fees that they can't cover. And so I think partnering has allowed for you to not only take care of your patients, but expand beyond that. And in particular, some of our work has been partnerships between federally qualified health centers, and if they don't have screening modality accessible within in-house, how they work meaningfully with partners that do screen. So this could look like something like you have with Stanford, where you can actually schedule, which is like really amazing. And that's already a barrier for a lot of partners to get access like that. But the fact that, it's really hard for you to get information once a patient leaves. And so even setting up some automated technology around, like, how am I going to know how the screening went, and if they need a diagnostic, or if they've been diagnosed, or if they're through treatment and now in survivorship, how do I support them? And so the specialized care that can occur at cancer centers and hospitals can really fill the gap that sometimes can happen in primary care when you have like a million other things to be doing. So I don't feel like we could do our work without finding the partnership, the pieces that where they can complement each other.
Great, thank you. And thank you, Anna, for that. And while we're on partnerships, Wendy, I know that your program as well there at Integrative. Could you give us some advice from your experience in building partnerships? What advice would you give to the health centers looking to form partnerships to expand their screening capacity?
I think understanding for us, what we found is there's more need than how often we can have mobile mammography in our local community. So I think maybe at the instead of your conversations, talking with that partner about what is that availability? What does their, future plans? Are they planning to add, more units that you'd be able to optimize? I'm sitting here thinking monthly, oh my gosh, that would be wonderful if we had mobile mammography monthly. So for us, they're so busy. We partner with WVU Cancer Institute and they go across the whole state. So they're, really reaching everyone across the state. And so we're limited on how many days we get to schedule. So I think that if you're looking at a partner, looking at that, and I really like the process that she outlined, thinking, oh, how can we optimize Epic on the front end? And I think so maybe, collaborating from the beginning, what that process should look like would be helpful to achieve the outcomes that you're looking for.
Great, thank you. Noria, would you like to add anything to that on identifying proper partnerships? And then we do have a question in the Q&A box.
Yeah, no, I think that, to me, it's a really, really great opportunity. I really can see, even if we don't have all the results we want right now, but we are sure in a short time, we can really open the door for more opportunity for our population. I think that is great, especially the learning we have between organizations, that is the support, that is amazing.
Yeah. All agree. Thank you. Question in the Q&A box. Do you accept walk-ins for cancer screenings or other clinical services? So this is to our health centers. Do you accept walk-ins for cancer screenings or other clinical services?
So we do accept walk-ins. We don't do the screenings on site, so if they couldn't walk in that day because it's just not available here. However, we accept walk-ins, whatever their need is, we're going to assess that. If this cancer screening is something that, comes up, then we would work with them to identify what that looks like. Do we have the mobile mammography coming anytime soon? If not, what are the other options? What are the local hospitals? We're kind of in between two different hospitals, 45 minutes either way before you can get to another hospital. So what works for the patient? What can they accommodate if they need that screening? We would talk through that with them.
Yeah, and while they were here, we would also talk to them about transportation. And if they needed transportation, we would arrange that for them.
Yeah, we found that if you have the patient captive in front of you, it's best to get as much into that conversation as you can, because sometimes it is difficult to reach patients afterwards. We have the same issue sometimes with telephones, and I think our patient population is very skeptical of answering any number they don't recognize. So depending on how it pops up on their phone, whether they will answer you and call you back. So we try to have all of that. If they walk in, they're a captive audience. We want to cover as much as we can.
Noria.
Yes, same thing. We have walk-in. However, it's just one day a month. Sometimes it's difficult, but yes, we really receive a walk-in patient. And also, if we don't have, for example, we don't have more slot for that day, we try to talk about the Stanford opportunity, because we can do the schedule immediately, just right there. So that is the good thing. So if we don't have for the mobile mammogram, we offer the Stanford, and we in our clinic, every clinic have educational material, and also how they can go through the Stanford when when they has to go there, we have everything ready for those patients who really need it. And the good thing is it's free. So if the patient is no insurance, so they can go directly to Stanford and we can do the schedule immediately. Yeah, that is a wonderful opportunity.
Thank you. All right, so moving on to a question, I have another question. Do you have any resources that can help uninsured patients when it comes to screenings? When it comes to BCS.
We offer the West Virginia Breast and Cervical Cancer Screening Program, and that's for uninsured and underinsured patients. And also, one of our local hospitals has the Pink Fund, which they raise money that'll cover mammograms for people that are uninsured.
Noria.
Yeah, we also, how I mentioned before, we have Stanford now. So, but also if the patient is on insurance and they cannot go to Stanford for different reasons, so we enroll the patient in every woman care program, and that patient can go anywhere. So that is the process. And that is part of the quality team, try to verify to be sure if the patient cannot go. Stanford can be enrolled immediately in that program because we don't want waste time, opportunity for our patients.
Anna, would you like to add any? We're looking at resources that help uninsured patients.
Similar breast and cervical health program in every state. Most of it's housed at the health department, like in Louisiana, where I used to live, it's housed at LSU, for example. But each state should have some type of program like that. Oftentimes, like the Safety Net Hospital in that state will also have some subsidy, like the PINK program that Wendy's team talked about. We also have a 1-800 number at ACS that if someone is struggling with finding access to like a system to go to, or has received a diagnosis and like needs connection or needs like support with funding or transportation, there are those options too. I can put a link in the chat to like we have like a homepage for breast cancer screening specifically for Awareness Month, and it includes like our 800 number, our app, like if people need support down the continuum as well, like even after diagnosis. So I can pop that in the chat, but echoing everything that was already said, that hopefully everyone has access to at minimum those state programs in your state.
Yeah, important. So let's talk. I had a question regarding diagnostic imaging or access, the women having access. Now, Noria, it sounds like you have a really good program because your program, you have direct access to Stanford, who kind of allocate designated slots for your health center. But Wendy, in your community, a question around diagnostic imaging. Are you experiencing the challenges of getting for your patients getting access, your women, to the diagnostic imaging centers for their screenings?
As of lately, when the providers write the order for the screening mammogram, they write it with ultrasound if needed, so that if the hospital sees something abnormal, they automatically have an ultrasound at that same appointment. So that saves some time for the patients.
All right. Let's see what else we have here by way of questions. Please know you're in the audience. Feel free to drop any questions that you have. What else would you like to know that's happening in the breast cancer screening world, and what's happening in the other health centers? So Anna, I believe this question is for you. Looking at the successes that you've made in your organization around breast cancer awareness and increasing the screenings. This question is, how are you planning to sustain efforts? And I guess this is a question to all of the panelists, then this could be a question for all. How are you planning to sustain the efforts that you've made so that you may continue making progress beyond this month around Breast Cancer Awareness Month? So this is
Great question. And I can echo, so we I myself am not embedded within a health system, but we work with health systems that do screening. And so we create programs and we try that in the design of the program that you have an understanding of where your data is and what your unique challenges are, and that the interventions that you choose are filling the gaps that you uniquely have and that you have the resources to do that. So it starts with even the planning phase before you roll out. And so we try to encourage that you should do things that have like empirical evidence to be effective in breast cancer screening. And so that oftentimes will be something a little bit more longitudinal, more so than events. Events are very helpful for education, but it can be hard to sustain isolated events. So when we think about how to design a program or how we work, we think of how can we sustain this, the people doing it, the process for doing it, and the technology. How can that make it sustainable? And so we try to focus on the 3 different buckets that the community guide recommends for breast cancer screening. So we have patient-directed interventions, provider, clinician interventions, and then access to care. So what are we doing to address the patient? So that could be patient reminders, that could be patient education for providers, provider assessment and feedback, provider reminders, EHR enhancements, standing orders. These are sustainable things that live in a space and don't necessarily require like a person. And education is really critical for new people coming on into your work so that they know the process that you have and they can be sustained. And then really that access to care bucket is really helpful for sustainability, that if you're creating processes to make it easier to like use mammography or work with an outside source, having like really formal agreements of what that process looks like so that no matter who shows up to work that day or what challenges there are, there's like a known process. So ideally people don't fall through the cracks. And we know that the most effective and sustainable interventions are when you do more than one bucket. So like not only doing patient stuff, but doing like patient and provider. And then another thing from the research is that really if you focus on more than 2 in the access to care, so that's like reduction of structural barriers, like Mammovan, extended hours, stuff like that, that it's even more likely to be impactful and sustainable. And so just trying to start with things we know work, but customizing it to your needs. Because I think if we look at the EBIs, evidence-based interventions, as a menu, I have found with my partners that it's really hard to sustain things that weren't really your problem to begin with or were just like too big. And it's hard when you're like in an intervention year. That's when everyone cares a lot, but you have to move on to something else with competing priorities. So what can we do that we can keep doing? It's not like if Anna doesn't show up, it's going to fall apart. So sorry, I don't know if that
No,
answered.
great. That's great. It certainly answers the question and gives us a real good glimpse of what you're doing in your space for sustainability. Wendy, we'll move over to integrative. Same question.
I think it's similar, but in a different context. So talking about planning, I think it's, inside of the center for us, it's that daily huddle. It's the planning ahead. It's being able to access that information and knowing in advance what we need to talk to our patient about. It's taking advantage of that technology so that you have that information. And how can we connect better to the outside organizations, the hospital systems that we're working with to get that information? I mean, technology is pretty advanced these days. So, what can we do? We ended up putting together a connection from their electronic medical record to ours. So those results are just immediate. We don't have to go searching for them. We don't have to wait for someone to have time to send them. So I think it's, staying on top of that and keeping it forefront of the staff, but then also not veering away from the standard. You build that standard workflow. It should become part of your everyday, but sometimes people kind of start to lean off of it. So you got to make sure that you're staying on track, moving forward, staying with that workflow so that no one slips through.
Gloria.
Yeah, I think the same, different context. But yeah, definitely for us, that is a multi-component intervention. That is key because that's really help us. For example, for us, it means pre-visit planning. This is something like the MA can do every single day. And we also has a weekly gap and care list for the next follow-up appointment. That help us a lot also because that is part of the huddle meeting we have too. So we can discuss, okay, how many of those patients we have in the schedule, they already the order was placed, etc. So I think all of that effort can help. And also we are building a robust care message intervention when we are educating patients, send post-appointment no-show, send post-appointment survey too. So I think all of this combined plus our Epic is working fantastic and for us, right? So, but we need a little more education about the workflow, how use the breast cancer health maintenance modifiers, right? So, because that can help the provider to really switch and say, oh, this patient is no longer breast cancer screening, it's a diagnosis. So that can help us a lot too. And we are working a lot in that part. Let me see if, and of course, the team collaboration, where referrals teams, community health impact, MA, provider working together, and especially the provider and MA working every single morning in the special huddles to see what is the challenge, right? What is the patient who really need our support? So that is exactly what we are doing, additionally to the mobile mammogram and the Stanford opportunity.
Great, Noria, for that share. Next question, we're still on sustainability, but it's around sustainability financially or funding. What creative ways what are you doing creatively, it looks like, to continue supporting your program through funding? So I know you need partnerships. One, you speak about partnerships with your local universities and colleges, but what other ways your health centers are maintaining or sustaining the funding to support your initiatives?
Well, I can go first. So I think one of the ways to be sustainable over the time is just when we work as a team, right? Because it's not depend one person. It's just it's depend what we have available. And to be honest, we as an organization are struggle a lot in this year, and we are really learning how optimize the resource we have. So that's why nobody is working like that is not my job. No, it's like, okay, how we can help, during this process to try to collaborate, especially when we don't have enough staff. That is one of the things, and it's working very well because we can really make the process sustainable from the organization point of view. For the patient, I think that can, when we focus in a special target population who really need the most, the screening, that help us to set up the funding to this population, and we can really optimize the results. That is our experience.
Great, thank you, Noria. Wendy.
Yeah. So community health center, we're wearing lots of hats. So I think it's paying attention to what's working and what's not. If we're, trying to do some outreach for, a subset of our population, was it effective? Did we reach those patients? Is it something we need to build upon, or should we look somewhere else? I think that, there really isn't a whole lot of funds to go around anyway. So when we're doing some outreach, we want to make sure that it's working and giving us the result that we want.
Anna, would you like to, anything to add to that when you look at sustainability and maximizing your resources within your programs?
So I can't speak as well to the financial piece since I'm not funded in that way, although very advocate for funding to continue for your systems. I guess one thing that popped up for me is prioritization, which is like a duh, but also it's like how. And so something that was kind of cool that was released in like the last month or two from the National Breast Cancer Roundtable. So that's a combination of like a coalition of many different organizations and supported by the American Cancer Society, is that they had a risk digital toolkit for assessing risk. And so I know we just talked about ultrasound for higher risk, but like there's certain things like genetic risk factors or family history, that starts bumping you into like the unknown of just like regular screening. And so that might require you to start being screened earlier, or that might require you to be screened at a more cadence and maybe get an MRI with your mammogram. So there's a lot of nuance, and part of the reason that so like there's been like a 44% decline in breast cancer mortality from 1989 to I think it was 2022. But not every group has experienced the benefits of that. And that's because of early detection and better treatment. But because of various factors like lack of certain populations in clinical trials, lack of access, that there are certain populations that might get higher screened, like Black African American are some of the highest screened in the national data, but they also have the lower incidence and 38% higher mortality than white women, where they have only 5%. I don't want to get this wrong. It's Black African American women have 5% lower incidence, so new cases, but 38% higher mortality. And a big reason for that is because when they do find cancer, it's at a later stage. So that limits your options and limits your survival. And so I think figuring out to get more bang for your buck, it was a interesting tool that I'll put in the chat as well. But how can you assess the risk of your patients? Because if they are at higher risk, you actually should start screening folks at 30. And so it just changing kind of like there's a standardization for average, and I think that's where most people sit. But like, I think 2/3 of cancers are found localized, but for populations that have higher mortality, they are found not localized, so distal, like so has spread at that point. And so I think I will put that in the chat, but maybe assessing something like risk and creating a workflow within your system to be able to identify those patients. Again, so that's extra credit. We're all doing our best to do like get the most people in without adding this extra criteria. But if I feel like you want to level up or stratify your data by populations that we know experience this disease worse, and targeting interventions towards those of the people that you serve that experience this worse, I think assessing their risk and making that automated or somehow sustainable in your system could be a way to go. So I'll put the digital toolkit in the chat. It has workflows and a case study, and it has information for providers, clinicians, and patients on how to assess that. But that it's not really answering the financial question by when you say yes to something, you have to say no to something else. So like, how can we get people faster to increase their like chance? I'll put that in the chat if that's helpful.
Yeah, thank you. Yeah, very helpful. So you mentioned risk assessment. So I'd like to spend another minute or so on risk assessment. Wendy, would you like to share when you look at risk assessment using your data? You mentioned data early on and how you're leveraging. So how are you using data there for risk assessment, to conduct risk assessment?
For risk assessment, I don't know that we've gone into that detail, though I really like what Anna was talking about. I'm sitting here thinking, how do we optimize our technology to help us accomplish that? Our data really is just around the community and the population. So that doesn't include a risk assessment, but it does include those risk factors. So if we look at it from that standpoint, we have an idea of where in our communities that patient population is more at risk. So we can focus on that depending on the type of outreach that we're doing or something along those lines.
Okay, thank you. Noria.
I think we do something similar. So I'm not sure if I can respond more properly this question, but this is what we do. So we usually break down the data. The data is our first a way to identify patient, right, who has more risk, but the risk is based essentially in the race and ethnicity, because Anna already explained our majority of our population is Black African American. So we increase already the rate of screening, but we know we usually get late with them. So that's why we try to prioritize that population. And the second way we are doing right now is identify what is the age of this population population who has the most higher rate, right? So for screening, and then we can start focus, especially, and surprisingly, is the younger population who has struggled the most with the screening, at least for our data. So that is the way we try to identify those patients. And also every time we talk with a patient, we ask questions about, okay, what is, how you feel? Do you have something, is alert to you? We immediately refer the patient to the provider. Even if the patient already have a screening referral, we refer again the patient to the provider because that patient needs a different approach. So that is how we are doing right now. So I hope this helps.
Yeah, thank you, Noria. Yes, thank you for providing that insight here. A couple of questions in the Q&A box. One question, what information do you wish you had, but you don't currently have access to, and why? So I guess this is this question around growing your screening program. What information do you wish you had, but you don't currently have access to, when you're looking at your current screening program and where you'd like to see it, how you would like to see it evolve? I think I'm reading that correctly. So we just spent some time on data. So I'm just trying to connect the dot, this question. So you spoke about data and how you're using data. Is there any additional information that you would like to have when you're looking at your current program, opportunities for improvement?
I would like to speak more about the data we are probably not using right now. We have the information, but we are not paying too much attention, and I will refer to the aging of the referral. So we usually tracking the response, right? Means if the patient complete the process and we do outreach. However, I really would like to start working more in the aging of the referral, because that can tell me if we are lacking in the process to reach those patients and understand why, if the referral was placed in January, the process is still without progress, right? So I think that is my goal for these months, because that is I think that can bring me a lot of more information. We can really work quickly. You know what I'm saying? Because we are seeing patients through the outreach, right? But we sometimes forgot, okay, how much has a referral, how much age has that referrals in our work queue without doing anything else, or without the communication. Probably we need to improve the workflow, or so many things. So, but that is one of the data we have, and probably we are not using so far.
Thank you, Noria. And so we did have a follow-up question, a little bit more. And that question was regarding data gaps and tool workflow gaps. So looking at your current gaps. Thank you. Thank you for giving a little bit more clarity behind your question. So Wendy, so looking at integrative healthcare system, health center, are there any data gaps or gaps that you are currently focused on, and any workflow tool gaps?
I think, one gap that we have is I don't know that we, truly understand the hesitancy of our patients. You have conversations, and sometimes I think there's assumptions, but I'm not sure that we really get the full picture of why some of our patient population isn't getting those mammograms. I would love to, 100% know the truth, what it is, so that we could help them overcome whatever it is. But I think there's a gap there in really understanding all of the barriers that our patients face, because, everyone's situation is completely unique, and, they may or may not feel comfortable sharing that information, depending on what they came in for. If they were a walk-in sick visit, they don't know the provider, they've just met them. Maybe they're not opening up as much as they would for a PCP that they've been with for years. So I think there's a gap there in trying to understand how we can truly help all of our patients.
Mhm. Yeah, so thank you for that. Anna, any insights when looking at data gaps or things you wish you could learn more about when it comes to looking at your screening programs with
Yeah.
CS?
I think if we were to focus on the data part, sometimes I think it can be really isolating and frustrating when you're like, okay, I'm experiencing this. This is our screening rate, but like how and like it's helpless. And but then you don't know like how it compares to the county or the state. And so I think like the time, luxury of time and expertise of people to pull down, because there's so much secondary data of like BRFIS or National Health Survey or the cancer like ACS reports that come out every year. So understanding kind of the landscape that you're living in and that there are like some positive deviants or folks that are in your area that actually have figured some stuff out. And so I think an attempt at trying this, I didn't do this, but a colleague of mine at ACS had created this screening atlas, like screening disparity atlas is I think the proper name. I'll put it in the chat. But they took a bunch of different secondary data sources and put them with like the GIS, like geospatial team. And you can add different filters to know kind of what breast cancer, for example, was one of them. Breast cancer screening in your like zip or county or state or nationally and how that compares. Because we know like the national, I think the last UDS measure nationally was like 54%, I think was the screening nationally for breast specifically. And so it's been steadily increasing over time, but if you're completely off from that, it's like that's a hard and like healthy people is like bye. I mean, that's the dream. We'll get there, but like it's just really hard to compare to something that doesn't is not like you. And there's even an FQHC filter on that atlas, so you can kind of see people that are like you and what they might look like. And so I think like kind of getting back to the partnership, like not only partnering with systems that are different than you, but systems that are like you. And so I think there's like this hunger of like, how are you guys doing it? Like, is it me? Like, it's screaming in the void if you're having challenges, and it's like never just you. So I think it just takes time, luxury, data. So I just always want to know more and know more patterns and know what people are doing. And sometimes it's hard to know.
Yeah, great. Thank you.
Yeah.
So Jess, you said we have a hand up. I'm sorry, I can't see that from here. Uh, Hand up, just please feel free to unmic and ask your question. No?
While we're waiting, there's also a question in the chat from
Yeah, I
Eric
see
Lopez.
Luz now.
Yeah. Oh, there he is.
Yes.
Who is?
You'll have to unmute. We see your hand up. All right, so we'll move to the Q&A box. Luz, if you're there and you can unmic, let us know. We'll come back to you. Real quick, how do you involve the community in this work? So looking at community health workers, patient navigators, health educators in the field. How are you involving the community in this work? Noria, I see you, right. That's a question in the Q&A box. How do you involve the community in this work? Community health workers and patients with lived experiences.
Yeah, what we do right now is through the community health impact team. They work directly with the community. They usually have events when they present and connect everything related with the screenings. That's include the three of them, but that is the way we are using right now, just to try and more in contact with the population, try to invite them. So, okay, how we can, as an organization, can help you. That is the role of the community health team and community health impact team. They are doing every single week. And another thing, they have another special touches with the as a community health workers too. So when they identify the patient who has a risk and they offer and connect with them about our programs we have and the opportunity the patient already have and refer to us internally. that is how we are doing that part.
All right. Thank you. Thank you for that, Chair. So we're coming down to the hour. Oh my goodness. We have about 4 minutes, 4 minutes remaining. So I'd like to use the last 4 minutes to ask the question here. I found a question. If you could share one key takeaway or a piece of advice for health centers working to improve breast cancer screening, what would it be? Do you need me to reread that question? All right, so one key takeaway or one piece of advice for health centers working to improve breast cancer screenings.
Okay. I would say I should have prepared this answer. I think my first thought was like to just start. I think it can be like really overwhelming, but I think if you can just start by looking at your data and just try something small before you scale. Just try fast and then go to the next, but just be informed by your unique experience and your unique community. That's where to start.
Yeah, to me is the multi-component part. So don't be afraid to do many things at the same time. So because sometimes we are waiting to do something perfect. No, just do it what you have and take the opportunity you have with the team you have. I think that is the best way to do that, and the continuity, because don't give up. So it doesn't matter what happened, the results, keep moving.
Okay, thank you. Noria, great advice on us. So Wendy, one key takeaway or advice just to improve breast cancer screening.
So I would say, don't think you're alone in this. You're probably, trying to accomplish or overcome a barrier that someone else has. So utilize your resources, network, especially, in FQHC. We're all working in this. We're all kind of have the same population. So finding ways to share some of those best practices or some of the things they've tried and didn't work, sharing of that information for me, I think is really optimizing your best resource that you have as someone who's already gone through it.
Thank you. Mary.
I would say don't assume that the staff is following the workflow that you have set forth before then. You've got to look at the charts. You've got to have somebody scrubbing those charts. You've got to have somebody being accountable and chasing down those orders and going after the patients and holding the staff accountable when there's missed opportunities.
Thank you. All great advice. Absolutely. I see. Yes, Eric Lopez had a question. Yes, we will follow up with you, Eric, on your question. And this question was regarding sick patients. Eric, feel free to unmic before we close out. If we want to get your question in real quick. No? Okay. He's having.
I think he said he had put it, what do you do if patients are coming in only for sick visits and don't have time for preventative topics? Patients don't show up for wellness preventative visits was the question.
Okay. All right. So we will certainly circle back, Eric. We will respond to your question. But we are going to, he said no mic, sorry. Okay. So we're going to wrap up. Thank all of our panelists for here. Thank you all for joining us for today's discussion. And a very special thank you to our incredible panelists, Anna, Wendy, Noria, and Mary. Thank you for sharing your time and your expertise. And we hope today's conversation sparked new ideas and offered some practical ways for you all to go back, to take back to your teams and your communities, whether it's expanding access through mobile screening, using data to prioritize outreach, or strengthening your partnerships to really make your work incredible and make a difference. So as we close our Breast Cancer Awareness Month, Let's carry this momentum forward. Every detection saves lives. And together we can contribute to continue to build our systems, right? And help more women get breast cancer screenings and greater outcomes as a result, better outcomes as a result. So thank you all again and enjoy the rest of your day.
Thank you.